Hello and welcome to Module 4 of the MBL Academy series, MBL-Producing Bacterial Infection Testing. When a patient shows signs and symptoms of an MBL-producing infection described in Module 3 and has a risk factor listed in Module 2, along with no improvement after beta-lactam antibiotic treatment, we suspect the infection could be an MBL-producing bacterial infection. In this case, testing is necessary to confirm the diagnosis. As well as testing for MBL production, we need to know whether we're up against Norman or one of his friends, as this will impact the antibiotic treatment regimen. UCAS guidelines are clear on how best to conduct the identification tests, and your hospital have their own guidelines to consult too. Identifying the bacterial species and what antibiotics work, which is breakpoint testing, should be conducted before testing specifically for MBL production. Early detection of MBL-producing bacteria is crucial for effective treatment and infection control. Delayed or inaccurate identification can increase the risk of treatment failure, prolonged hospital stays, and increase the risk of morbidity and mortality. Patients with MBL-producing infections often need extended antibiotic courses and alternative treatment strategies which can be less effective and more toxic. Testing to confirm the presence of MBL-producing bacteria early helps to guide antibiotic therapy and prevent further spread to other patients, staff, or the community. There are two main types of tests for MBL-producing bacteria: phenotypic and genotypic. Phenotypic tests examine the observable characteristics of the bacteria, while genotypic tests analyse their genetic makeup. Remember the Pacman metallobeta-lactamase enzyme we saw in Module 1? Well, the phenotypic tests use specific chemicals to stop the zinc molecules from binding, which inhibits the enzyme from degrading the antibiotic. Firstly, we are going to start with phenotypic tests that assess antimicrobial susceptibility. These tests directly assess how susceptible the bacteria are to antibiotics. For MBL-producing bacteria, we will specifically assess their susceptibility to beta-lactam antibiotics. All phenotypic tests for antimicrobial susceptibility are conducted following the UCAS guidelines or your local guidelines. Now, let's take a closer look at these tests. The MBL epsilometer test, also known as the E-test, is used to determine the minimum inhibitory concentration, or MIC, which in this case is the lowest concentration of a beta-lactam antibiotic required to inhibit bacterial growth. A lack of growth inhibition or specific growth patterns can be used to determine what is causing the antibiotic resistance. On screen we can see the 3 bacterial growth inhibition patterns indicative of MBL-positive bacteria. However, all MBL-positive bacteria should be sent to a reference laboratory for genotypic testing. This test typically takes around 16 to 20 hours. However, slow-growing gram-negative, non-fermenting bacteria can take up to 48 hours. It is a highly sensitive and specific test, but can be expensive. Next, we are going to explore the double-disc synergy test, or DDST, which, like the E-test, is based on inhibition zones. On screen, we can see a petri dish inoculated with bacteria and 2 antibiotic discs. An enhancement of the zone of inhibition in the area between the 2 discs, larger than 5 mm, is indicative of an MBL-positive bacteria. The bacteria should then be sent to a reference laboratory for genotypic testing. This test typically takes around 16 to 18 hours. It has good specificity and sensitivity and is a low-cost test. Like the double-disc synergy test, the combined disc test also uses 2 antibiotic discs. However, they are spread apart. On screen, we can see our petri dish. An increase of 7 mm of the zone of inhibition around the EDTA and IMP, which is our example antibiotic disc, compared to the imp disc indicates MBL-positive bacteria. The bacteria should then be sent to a reference laboratory for genotypic testing. Like the double disc test, this test typically takes around 16 to 18 hours and has good specificity and sensitivity, as well as being low cost. Next, we are going to discuss genotypic testing. Genotypic testing involves studying the genetics of the bacteria to help identify it. It has several advantages, including accuracy and speed. However, it can be expensive and may not be available in all laboratories. In Module 1, we discussed some of the genes that are responsible for MBL production in bacteria. These include VIM1, otherwise known as BLA-VIM1, NDM, BLA-GIM1, and IMP1. We can use a polymerase chain reaction, or PCR, to detect these genes and confirm the presence of MBL-producing bacteria. Multiplex PCR can also be used to detect multiple genes at the same time. PCR genotypic testing can be done in a much shorter time frame than phenotypic tests. Once a result confirming the presence of an MBL-producing bacterial infection is obtained, the findings should be urgently reported back to the clinical team responsible for the patient. Key information should include patient ID, hospital unit, and date of sample collection, sample type, the identified organism, detection of MBL production including genotype like VIM1, NDM, BLA-GIM1, and IMP1, the antimicrobials found to be ineffective, potentially effective treatment agents identified. It is also important to check whether the infection is classed as notifiable. Information like resistance genes can be used for wider surveillance and help to identify how the resistance was acquired. And there you have it, the fourth module is complete. Be sure to join me in the next module to learn about best practices in patient care.